Thank you, everyone. It's now noon on East Coast time, 9 a.m. on Pacific time, and I wanted to welcome everyone. Today is November 19th, 2021, and I'm pleased to call our ACIP meeting to order. I'm going to start by turning it over to Dr. Melinda Wharton to run through our announcements for the morning.
Thank you, Dr. Lee. Good afternoon and welcome to the November 19th virtual ACIP meeting. Next slide, please. Copies of the slides being presented at today's meeting are available on the ACIP website. Additionally, slides are available through a share file link for ACIP voting, liaison, and ex officio members. A few notes on meeting logistics for those who are listening in on the Zoom line. Please mute your lines at all times until you're called on for discussion, and when Dr. Lee opens the meeting for discussion, please virtually raise your hand. During the discussion period, Dr. Lee will take questions first from ACIP voting members and then from ex officio members and liaison representatives. Please disable your video. A profile picture is fine, just no live video. And we'd ask ACIP members to turn on their video during votes. Next slide. The Advisory Committee on Immunization Practices is, at its heart, a public body. Engagement with the public and transparency in our processes is vital to the committee's work. For this meeting, we will be holding one oral public comment period at approximately 1 p.m. Eastern. To create a fairer and more efficient process for requesting to make an oral comment, people interested in making an oral comment are requested to submit an online request in advance of the meeting. Priority is given to those advance requests, and if more people request to speak than can be accommodated, we conduct a blind lottery to determine who the speakers will be. Speakers selected in the lottery for this meeting have been notified in advance of the meeting. Members of the public can also submit written public comments via regulations.gov using docket number ID CDC 2021-0125. Information on the written public comment process, including as well information on how to make a comment, can be found on the ACIP meeting website. Next. As noted in the ACIP policies and procedures, members of the ACIP agree to forgo participation in certain activities related to vaccines during their tenure on the committee. For certain other interests that potentially enhance a member's expertise while serving on the committee, CDC has issued limited conflicts of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but these members are prohibited from participating in committee votes on issues related to those vaccines. Regarding other vaccines of the concerned company, a member may participate in discussions with the provision that he or she abstains from all votes related to the vaccines of that company. At the beginning of each meeting, ACIP members state any conflicts of interest. And with that, I will return the podium to Dr. Lee.
Thank you, Dr. Wharton. Before we get started with roll call, I wanted to let the public know that because this meeting was not scheduled until a few days ago, not all of our members could be in attendance today due to responsibilities that could not be rescheduled at the last minute. I also wanted to acknowledge and sincerely thank the colleagues of our committee members who have often during this pandemic rescheduled their own days in order to provide coverage for many of us, including caring for patients, so that we are able to attend these emergency meetings. We recognize that it is not only our ACIP members who are the public servants, but also our colleagues, our friends, and our family members who enable us to serve in these roles. And so we thank them for their service. For our committee today, we do have quorum, and so we are able to proceed. And I will now take roll call, starting with ACIP members and then ex officio members and liaisons. As a reminder for ACIP members, I'll ask you to state your name, affiliation, and whether you have any conflicts of interest. For my members, I'm just going to warn you, I might skip around a bit, so just be prepared to respond. And today I am going to start with Dr. Alt.
My name is Kevin Alt, and I'm an obstetrician and gynecologist at the University of Kansas Medical Center in Kansas City, Kansas, and I have no conflicts.
Thank you. Next, I will move to Dr. Cotton.
Good afternoon. It's Camille Cotton. I am the Clinical Director of Transplant and Immunocompromised Host Infectious Diseases at Massachusetts General Hospital and Associate Professor at Harvard Medical School. I have no conflicts. Thank you.
Thank you. Dr. Sineas.
I am an internist and pediatrician. I am an associate professor of medicine, pediatrics, and medical science at Warren Alpert Medical School at Brown University. No conflicts.
Oh, thank you so much. And Ms. Bata.
Good morning, Lynn Bata. I am a public health nurse serving as the immunization clinical consultant for the Minnesota Department of Health, and I have no conflicts.
Thank you. Dr. Lair.
Dr. Jamie Lair, I'm a family physician in Ithaca, New York in private practice, and I have no conflict.
Thank you. Dr. Brooks.
Oliver Brooks, Chief Medical Officer at Watts Healthcare Corporation, no conflicts.
Thank you. Dr. Paling.
Good afternoon. This is Kathy Paling. I am a professor of pediatrics and epidemiology and prevention at Wake Forest School of Medicine, Atrium Health, Wake Forest Baptist, and I have no conflicts. Thank you.
Thank you, Dr. Paling. Dr. Sanchez.
Good afternoon. This is Pablo Sanchez. I'm a neonatologist and pediatric infectious disease specialist at Nationwide Children's Hospital and the professor of pediatrics at the Ohio State University College of Medicine. Thank you.
Thank you. Dr. Talbot.
Good morning. This is Kip Talbot. I'm an associate professor of medicine and infectious diseases at Vanderbilt University Medical Center, and I have no conflicts.
Thank you. We will go to Dr. Chen.
Wilbur Chen, professor of medicine. I'm also the director of the university's travel medicine practice at the University of Maryland School of Medicine, and I work at the Center for Vaccine Development and Global Health. I do have a perception of conflict. It does not present a real conflict, but my employer, the University of Maryland, has a grant from Emergent Biosolutions that supports the work that I do on developing a Shigella vaccine.
Thank you, Dr. Chen. Dr. Daly.
Matt Daly here. I'm a senior investigator at the Institute for Health Research at Kaiser Permanente, Colorado. I'm also an associate professor in the Department of Pediatrics at the University of Colorado School of Medicine, and I have no conflicts.
Thank you. Dr. Long, are you on?
Yes, I am. Good afternoon. This is Sarah Long. I'm a professor of pediatrics at Drexel University College of Medicine and Chief Emeritus of the Section of Infectious Diseases of St. Christopher's Hospital for Children in Philadelphia, and I have no conflict.
Thank you, Dr. Long. And I am Grace Lee. I am professor of pediatrics at Stanford University School of Medicine, Associate Chief Medical Officer at Stanford Children's Health, and I have no conflicts. Next, we will go to our ex officio members, and I will, as a reminder, just announce the organization name and just please indicate your name and if your first name and last name and if you're present. So first, we'll go to the Centers for Disease Control and Prevention.
Good morning, Sam Posner, National Center for Immunization and Respiratory Diseases. I am here.
Thank you. Food and Drug Administration.
Good morning, Dorn Fink, representing the U.S. Food and Drug Administration Office of Vaccines.
Thank you. Health Resources and Service Administration.
Dale Mishler standing in for Dr. Mary Rubin.
Thank you. Indian Health Service.
Good morning, this is Dr. Matthew Clark, representing the Indian Health Service.
Thank you. NIH.
Good morning, John Bible, National Institute of Allergy, Infectious Disease, NIH.
Thank you. And Office of Infectious Disease and HIV/AIDS Policy.
David Kim, representing the Office of Infectious Disease and HIV/AIDS Policy, Office of the Assistant Secretary for Health.
Thank you, Dr. Kim. And I just want to acknowledge that Ms. Mary Beth Hance from the Centers for Medicare and Medicaid Services will be joining today, but just a few minutes late. We'll move on to our liaison representatives. American Academy of Family Physicians.
Hello, Pamela Rockwell, Professor of Family Medicine at the University of Michigan, liaison to the American Academy of Family Physicians. Thank you.
Thank you. American Academy of Pediatrics.
Good morning, everybody. This is Bonnie Maldonado, and I'm Professor of Global Health and Infectious Diseases at Stanford University School of Medicine, and I'm the Chair of the Committee on Infectious Diseases for the American Academy of Pediatrics.
Thank you. American Pediatrics Red Book.
Dr. Kim Berlin couldn't be here today.
Thank you, Dr. Maldonado. American Academy of Physician Assistants.
Good morning. This is Marie-Michelle Leger from the American Academy of Physician Associate. I'm the Director of Clinical Education.
Thank you. American College Health Association.
Hi, this is Sharon McMullen, Cornell University, and also rolling in for my co-liaison representative, Dr. Tavi Chai, University of North Carolina at Chapel Hill.
Thank you. American College of Nurse Midwives.
Carol Hayes, present.
Morning. American College of Obstetricians and Gynecologists.
Good morning. This is Dr. Linda Eckert at the University of Washington in Seattle, representing ACOG as the liaison. Thank you.
Thank you. American College of Physicians.
Good morning. Jason Goldsman, General Internal Medicine Private Practice, Affiliate Associate Professor at Florida Atlantic University, representing the American College of Physicians. Pleasure to be here.
Thank you. American Geriatric Society.
And Schmader for AGS, present.
Thank you, Dr. Schmader. America's Health Insurance Plans.
Yeah, this is Bob Gluckman, present. Thank you.
Thank you. American Immunization Registry Association.
Good morning, good afternoon. This is Rebecca Coyle representing ERA.
Thank you. American Medical Association.
This is Sandra Freihofer, practicing general internist in Atlanta, adjunct associate professor of medicine at Emory, representing the American Medical Association.
Thank you. American Nurses Association.
Carol Hayes, representing ANA for Chad Riddle today.
Thank you. American Osteopathic Association. We'll move on to the American Pharmacist Association.
Good morning. This is
Oh, sorry. Thank you. Yeah, thank you, Dr. Grog. We hear you, and you're here for the American Osteopathic Association. I think your audio is running a little slow, so we'll mark you as present. And we'll go back to the American Pharmacist Association.
Good morning. This is Dr. Michael Hogue, Dean and Professor of Pharmacy at Loma Linda University and Professor of Preventive Medicine at Loma Linda University School of Medicine, representing the American Pharmacists Association.
Thank you. Association of Immunization Managers.
Hi, this is Claire Hannon, Executive Director of the Association of Immunization Managers.
Morning. Association for Prevention, Teaching, and Research.
Rick Zimmerman at the University of Pittsburgh, present.
Thank you. Association of State and Territorial Health Officials.
Everyone, this is Neeraj Shah. I'm the Director of the State of Maine CDC and the President of ASTO. Thank you.
Thank you. Biotechnology Innovation Organization.
Good afternoon. Phyllis Arthur representing Bio.
Thank you. Council of State and Territorial Epidemiologists.
Hi, Dr. Christine Hahn representing CSTE.
Thank you. Canadian National Advisory Committee on Immunization.
Matthew Tunis here from the Public Health Agency of Canada on behalf of the National Advisory Committee on Immunization.
Thank you for joining. Infectious Disease Society of America.
Good morning, Dr. Lee. Jeff Duchin, Health Officer, Public Health, Seattle and King County, Professor of Medicine, University of Washington, Division of Infectious Diseases and School of Public Health.
Good morning and welcome. International Society for Travel Medicine.
Good afternoon, Elizabeth Barnett, representing ISPM.
Thank you. National Association of County and City Health Officials.
Good morning. This is Matt Zahn representing NACHO, present.
Thank you. National Association of Pediatric Nurse Practitioners.
Greetings, Patsy Stinchfield representing NAPNAP.
Thank you. National Foundation for Infectious Diseases.
Hello, this is Dr. Bill Schaffner, Professor of Preventive Medicine and Infectious Diseases at Vanderbilt and Medical Director of the NFID.
My understanding correct on that?
Thank you. Next, we have National Medical Association.
Hold on, I'm on silent.
Oh, sorry. Thank you. National Medical Association. We'll move on to the Pediatric Infectious Disease Society.
Good morning. Sean O'Leary representing PIDS.
Morning. Pharmaceutical Research and Manufacturers of America.
Good afternoon. Corey Robertson, present.
Oh, sorry. Good afternoon. Thank you. Society of Adolescent Health and Medicine. And Society for Healthcare Epidemiology of America.
Good morning. Marcy Dries, Chief Infection Prevention Officer at Christiana Care, representing SHEA.
Perfect. Thank you, everyone. Are there any additional liaison members who would like to state their attendance that I missed? Okay. So with that, we will move on, and we do have some brief opening remarks by Dr. Sam Posner, the Acting Director of NCIRD. So I'd like to turn the floor over to Dr. Posner.
Thank you, Dr. Lee. I want to start off by thanking the ACI members for so rapidly coming together to deliberate the question of expanding groups who may get the booster dose. I know we've asked a lot of you this year, and we really appreciate all the work that you have done and continue to do for this response. ACIP, as you know, ACIP is unable to expand groups for vaccination until the FDA authorizes those persons in the EUA. Although the ability to mix and match doses has made parts of the implementation easier, we clearly understand that the prior FDA groups were complicated to implement. Importantly, simplification of our booster dose recommendations will reduce confusion and allow healthcare providers and the public health workforce to focus on high priority groups for boosters, as well as continuing to implement pediatric and the primary series vaccination. I also want to take this opportunity to remind people that we also need to ensure that people get the flu shot this season. We are already seeing increased circulation of both COVID and flu, and we have vaccines to protect us from both. Thank you.
Thank you so much for your remarks, Dr. Posner, and setting the stage for today's meeting. Next, I'll invite Dr. Doran Fink to provide updates this morning from the FDA.
Thank you, Dr. Lee. And once again, good afternoon. This morning's FDA emergency use authorizations expand the populations eligible for a single COVID-19 vaccine booster dose to include all individuals 18 years of age and older who have completed primary vaccination with an FDA authorized or approved COVID-19 vaccine, regardless of the vaccine used for primary vaccination. So these authorizations apply both to homologous booster doses, where the same vaccine is used for both primary vaccination and booster dose, as well as heterologous booster doses, where one vaccine is used for primary vaccination and a different vaccine is used for the booster dose. The authorized interval between completion of primary vaccination and a booster dose remains tied to the vaccine used for primary vaccination, meaning that individuals who receive a primary series of Pfizer or Moderna COVID-19 vaccines are eligible for a booster dose beginning at 6 months after completion of their primary series, while individuals who receive primary vaccination with the Janssen COVID-19 vaccine are eligible for a booster dose beginning at 2 months after their primary vaccination. FDA's assessment of benefits versus risks for expanding booster dose eligibility following primary vaccination with Pfizer and Moderna COVID-19 vaccines relied primarily on clinical trial data previously reviewed when booster doses for these vaccines were first authorized for use, and real-world evidence regarding effectiveness of Pfizer and Moderna COVID-19 vaccine primary series, preliminary safety information from use of Pfizer and Moderna COVID-19 vaccine booster doses in the U.S., and relevant safety and effectiveness information from use of Pfizer mRNA COVID-19 vaccine booster doses in Israel. In considering the recently increasing incidence of COVID-19 in the U.S. and abroad, including breakthrough cases in vaccinated individuals, and newer evidence providing reassuring information about the risks of myocarditis and pericarditis following mRNA COVID vaccine booster doses, FDA determined that the known and potential benefits of expanding booster dose eligibility for these mRNA COVID-19 vaccines now clearly outweigh the known and potential risks. It's important to note that even with evidence of waning vaccine effectiveness among vaccinated individuals, the predominance of serious COVID-19 outcomes remains among unvaccinated individuals. Thus, FDA acknowledges that while the impact of expanding booster dose eligibility is expected to be most clear on the individual level, that is, providing additional protection to vaccinated individuals against breakthrough cases of COVID-19 and potential serious consequences, the greatest impact on a population level is still dependent on increasing vaccine uptake among those who are eligible for primary vaccination but still unvaccinated, as well as maintaining scientifically proven non-pharmacologic measures for reducing transmission of the SARS-CoV-2 virus as we head into the winter months. Thank you.
Thank you, Dr. Fink. That was an excellent summary of where we are today and how we got here and what we hope to do going forward. I just want to take a moment to recognize our colleague from Center for Medicare and Medicaid Services. Ms. Hans, are you on the line?
I am. Thank you.
Thank you. So we'll just indicate you are present.
Great. Thank you so much.
You're welcome. Thank you for reminding me, Dr. Fink, that it is actually afternoon on the East Coast. So we will move on to the first session for the day. During today's meeting, I will invite individuals to contribute to the discussion. Please raise your hands electronically, and I will call on ACIP members first, followed by our Acpacip members and liaisons. And if you wish to respond to a particular comment or question, please indicate this electronically. Dr. Matt Daly, chair of the COVID-19 Vaccines Work Group, will provide an introduction and overview of today's meeting. Dr. Daly.
Thank you very much. So today I'll be presenting on behalf of the ACIP COVID-19 Vaccines Work Group. Next slide, please. There have been over 47 million cases of COVID-19 in the U.S. Since the start of the pandemic, and there have been over 764,000 deaths from COVID-19 in the U.S. And given the availability of vaccines that have a high degree of safety and real-world effectiveness, death from COVID-19 is, for most people living in the United States, vaccine preventable. The most recent wave of COVID-19 peaked in early September nationally, but unfortunately, case counts have been rising again for approximately the last 3 weeks. And I would highlight that in some parts of the country, there's rapid rise in case counts. Here in Colorado, for example, we recently reinstituted our crisis standards of care. Next slide, please. So this slide highlights the COVID-19 work group activities in November of 2021. Those activities have primarily been focused on booster doses. So in that context, the work group has heard Pfizer-BioNTech clinical trial data for booster doses. The work group has also received safety updates regarding booster doses and reviewed grading of the evidence. And we've reviewed and discussed updates to the evidence to recommendations framework regarding booster doses, and then had a very informative discussion about booster policy options. Next slide, please. So as we've just heard from Dr. Fink, this morning, the Food and Drug Administration expanded eligibility for COVID-19 vaccine boosters. And as Dr. Fink described, this authorizes the use of a single booster dose for all individuals 18 years of age and over after completion of a primary vaccination series with any FDA authorized or approved COVID-19 vaccine. Next slide, please. We did want to provide an update about COVID-19 vaccination among children 5 to 11 years of age. So as you can see on the slide, almost 2 million first doses have been administered to children age 5 through 11 years of age through the 17th of November. This represents 6.2% of all children 5 to 11 years of age in the U.S. who've received a first dose of Pfizer-BioNTech COVID-19 vaccine. In addition, I want to discuss safety for a moment. As we've talked about at prior ACIP meetings, the vaccine safety monitoring system that's been put in place to monitor the safety of COVID-19 vaccines is the most intensive ever for any vaccine. And all of those systems, including VAERS, VSD, and the BEST system and other systems, are all very closely monitoring the real-world safety of COVID-19 vaccines in 5 to 11-year-olds. Additionally, while I know this is not the area of focus for today's meeting, I want to go off script for just a minute and just say that I've been hearing from and talking with kids about COVID-19 vaccination, and many kids are very excited to get vaccinated. Not about the poke, but about the promise. They know their parents have been very worried about COVID infections, and they think that getting vaccinated will allow them to return to some level of normalcy, both in school and outside school. But what's been really striking to me is that kids in this age range, especially the ones that are a little closer to 10 or 11 years old, they've also brought up their social responsibility. They've described wanting to protect their classmates, their parents, their grandparents, their community. And while acknowledging all of this, I also want to say that we've heard from parents who've been offered but declined COVID-19 vaccination for their children. And to those parents, I'd say the door is always open. So please let us know what your questions or concerns are, and we'll help you as best we can. Next slide, please. So this slide shows data that's not publicly available on the CDC's website yet, but will be very soon. So treat this as preliminary, but here's a preview, and there's more data to come. On the x-axis is the date, and then y-axis is the number of first doses administered. And as you can see, over the course of the last, I don't even know what day it is, it's the 19th. So over the course of the last 16 days, we've seen a marked increase in the number of doses administered per day. And right now we're averaging more than 200,000 doses per day given to 5 to 11-year-olds in the US. Next slide, please. So I also wanted to take this moment to highlight for the audience a new development, which is around emergency use instructions. And to provide a little bit of context, patients and providers have had questions about how to approach individuals who received a non-FDA authorized or approved vaccine. And these questions have come up in the context of additional doses for those individuals and booster doses. So I just want to highlight that there's details on the CDC's website under interim clinical considerations that discuss emergency use instructions for COVID-19 vaccine by Pfizer-BioNTech. And so as you can see on the slide, on November 17th, the CDC issued emergency use instructions, and this is related to Food and Drug Administration authorized vaccines. So the EUA authority, as you can see, allows the CDC to create and issue an EUI, or emergency use instruction, to permit emergency use of an FDA approved medical product. Next slide, please. And so then, as I mentioned, the EUA covers the use of Pfizer-BioNTech COVID-19 vaccine for those who've completed primary vaccination with a non-FDA authorized or approved COVID-19 vaccine, such as certain people who are vaccinated outside of the U.S. with a COVID-19 vaccine, as listed for emergency use by the WHO. And this also includes certain participants in COVID-19 vaccine clinical trials, either within or outside the U.S. And then the EUA specifically provides information about use, including additional primary doses for those who are immunocompromised, and then a single booster dose among certain adults aged 18 and over. And the asterisk highlights that this is in interim clinical considerations, available on the web. Next slide, please. And then here are the fact sheets. And I just want to highlight that all of this detail is available again on the web, but I won't go into any more detail here. Next slide, please. So moving to the agenda for today, first we're going to hear from Dr. Perez from Pfizer, who's going to review efficacy and safety of BNT162b2 booster dose. Following Dr. Perez's presentation, we'll hear from Dr. Das at Moderna, who's going to provide an update on boosters from the Moderna perspective. Then we'll have a brief break, followed by a public comment period. After the public comment period, we'll hear from Dr. Shimabukuro from the CDC, who's going to give an update about COVID-19 vaccine booster dose safety. Following Dr. Shimabukuro's presentation, we'll hear from Dr. Talbot, who's the chair of the VAST group, and she'll provide a vast summary of interpretation of the current evidence regarding booster dose safety. Following that, we'll hear from Dr. Oliver from the CDC, who will review updates to the evidence recommendations framework regarding Pfizer, BioNTech, and Moderna COVID-19 vaccine booster doses. And following this, we will have a vote. Next slide, please. I'd like to sincerely thank all of the ACIP COVID-19 vaccines workgroup members, including ACIP members, ex officio members, liaisons, and consultants, as well as the outstanding leadership of Dr. Sarah Oliver. Next slide, please. And then a number of CDC participants who've worked tirelessly to prepare material for the COVID-19 vaccines workgroup to review. Next slide, please. Thanks very much. I'll turn it back to you, Dr. Lee.
Thank you, Dr. Daly. And we'll move right to Dr. John Perez from Pfizer, who will be presenting on the efficacy and safety of BNT162b2 booster doses.
Good afternoon. My name is Dr. John Perez, and today I have the pleasure of presenting the safety and efficacy of a booster dose of BNT162b2 from our 1031 study. Next slide, please. So we recruited 10,000 individuals who are 16 years of age and older who completed a 2-dose primary series of BNT162 in study 1001. The subjects were randomized to a 1-to-1 ratio to receive either BNT162 30 micrograms or a placebo dose at least 6 months after the second dose. Randomization was stratified by age, such that approximately 60% of the participants enrolled would be at least 16 years of age to 55, and the rest would be greater than 55 years of age. Assessments included safety evaluations of adverse events and COVID-19 case surveillance, or booster efficacy estimation after the booster dose. Reactogenicity was not collected in the study, but booster reactogenicity was reported from study 1001 and previously presented to this group. Next slide, please. So if you look at demographics, you can see we had equal participation by the sexes between the vaccine and placebo group. About 79% of the subjects were white, about 15% were Latino, and about 86% were from the United States. Next slide, please. If we look at age, you can see that roughly 56% were between 16 and 55 years of age, and the rest were greater than 55 years of age, with a median age in the study of 53 years. You can also see that about 5.4% were positive for SARS-CoV-2 at baseline. Next slide, please. Now, if we look at when the booster was given after completing the 2-dose series, you can see that the median time to get that booster dose was about 10.8 months after completing the 2-dose series. You can also see that the majority of people were between 10 and to less than 12 months. Next slide, please. Now, if we look at the time of follow-up after the booster dose, you can see that we followed individuals for a median of 2.5 months after their booster dose. Next slide. And next slide, please. So first, let's review reactogenicity. So this is an analysis that was requested by CDC for us to do. This is data from the 1001 study. So what you're seeing is reactogenicity of a booster dose with at least a grade 3 or higher in severity. So what you can see is overall about 6.6 had a grade 3 event or higher. If we look at local reactions, you can see that all the local reactions at grade 3 or higher were less than 1%. And if we look at systemic events, about 5.6% reported a grade 3 reaction, the majority of which was 4.5% for fatigue, followed by muscle pain, and then followed by headache. So overall, low rates of grade 3 or higher reactogenicity was reported. Next slide, please. We turn our attention now to adverse events. Here, what you're seeing is adverse events 1 month after the booster dose. So on the y-axis, you see the proportion of subjects reporting an adverse event. And on the x-axis, you see various categories of adverse events. And what you can see is something that we've actually seen before in COVID-19 clinical trials. Namely, we see a higher rate of adverse event and related adverse events being reported for the vaccine group as compared to the placebo group. And we see very low rates of SAEs, related SAEs, withdrawals due to AEs, and deaths reported in this group. Now, if you go to the next slide, please. So here, if we analyze the adverse events that are being reported at greater than 1% by system organ class, or SOC, after the booster vaccination, what we see is a similar pattern than what we've seen before. Namely, the adverse events that are being reported in the clinical trial are primarily adverse events reflective of reactogenicity. So what you can see is in the most common one, general disorders and administrative site conditions. This is the SOC where you would find injection site and systemic reactions such as fever, fatigue, and chills. In the musculoskeletal system, that's where you would find myalgia and arthralgia. In the nervous system SOC, you would see headache. And in the blood and lymphatic system disorders, you would see lymphadenopathy. In this study, we found the rate of lymphadenopathy was 2.7%. And as a reminder, that's compared to 0.4% that we saw after the second dose in the 1001 study. Next slide. And then if we continue to follow subjects out to our cutoff date was the 5th of November, we see the same pattern we saw at 1 month after the booster dose. Namely, that there are more adverse events reported in vaccine versus for placebo. But if you go to the next slide, what you can see is we still see adverse events related to reactogenicity in the SOCs that we previously examined. We are not picking up additional new adverse events or safety signals with the follow-up data. Next slide, please. So now if we turn our attention to serious adverse events by system organ class after the booster vaccination to the cutoff date, what we found was that the rate of serious adverse events was higher in the placebo group than in the vaccine group. So specifically, you saw that there was 16 SAEs of 0.3% in the vaccine group compared to 24 events in the placebo group, or 0.5%. And if you scan down the list, what you can see is that there's really no imbalance in any of the SOC categories that we see. So relatively equal between the various groups. Next slide, please. So if we focus on the related serious adverse events from the booster vaccination, you can see that there were 3 in the vaccine group and 2 in the placebo group. Very, very briefly, the first was a young male with the past medical history of postural orthostatic tachycardia syndrome and orthostatic hypertension who developed tachycardia consistent with these medical diagnoses 8 days after booster vaccination, was moderate in nature and resolved 2 days later. The next case was an elderly female with Gilbert syndrome who developed moderate hepatic enzyme increase that occurred 5 days after the booster vaccination and resolved over a month later. Importantly, she was taking Tylenol for diverticulitis that started 2 days before the booster dose. The next case was a young female who developed mild hepatic enzyme increase that occurred 49 days after the booster vaccination and was ongoing at the time of the cutoff. She saw her primary care physician who thought that this was due to atorvastatin. In the placebo groups, there was an elderly female who had multiple risk factors for cardiovascular disease who developed an acute myocardial infarction 9 days after the placebo dose. It was life-threatening, but it resolved 4 days later. And finally, there was a young adult male with supraventricular tachycardia who developed chest pain of unknown origin that occurred 6 days after placebo. It was severe in nature and resolved without treatment 1 day later. The subject was evaluated and troponin and ECGs were normal. Next slide, please. And next slide. So now let's look at efficacy. So what you see before you now is relative vaccine efficacy during the blinded follow-up period in subjects without evidence of infection prior to 7 days after dose 2. Now keep in mind, subjects in the vaccine and in the placebo group both had 2 primary doses of vaccine roughly 21 days apart. And they were randomized to receive either a booster dose or a saline injection. With that said, you can see that there were 6 cases in the vaccine group who developed symptomatic COVID-19 and 123 cases in the placebo group, which calculates out to a relative vaccine efficacy of 95.3. You go to the next slide, please. Here, what we're seeing is relative vaccine efficacy in subjects with or without evidence of infection prior to 7 days after the second dose. So now we're including people with evidence of infection. And what you can see is that there were 7 subjects randomized to a booster dose who developed symptomatic COVID-19 compared to 124 people in the placebo group, which calculates out to a relative vaccine efficacy of 94.6%. Next slide, please. Here, what you see is the cumulative incidence curve for first COVID-19 occurrence after booster vaccination. And the red line is the placebo group, and the blue line is the vaccine group. And what you can observe on the graph is that actually the 2 curves diverge starting prior to 7 days after the booster dose, and then maintain separated with additional follow-up time. The 2 dots that you see in the red curve are severe cases. These cases met the severity criteria because they had an O2 sat less than 93%. They were not hospitalized. Next slide, please. So if we look at relative vaccine efficacy by subgroup, what we see here with demographic characteristics along the left side of the slide and relative vaccine efficacy along the right, what we see is that irrespective of age, sex, race, or ethnicity, we can see that the relative vaccine efficacy was high, irrespective of demographic variable. Next slide, please. And then if we further analyze the data by country and by comorbidity, what we find is high rates of relative vaccine efficacy by country, and also high rates of relative vaccine efficacy whether someone had a comorbidity or not. Next and final slide, please. In conclusion, high relative vaccine efficacy in the boosted group compared to the unboosted group 7 days after the boost. Those without evidence of infection gave a relative vaccine efficacy of 95.6%. None of the protocol-defined cases of COVID-19 in the unboosted placebo group resulted in hospitalization. 2 cases of severe COVID-19 occurred in the placebo group based on an O2 sat less than 93%. Multiple subgroup analyses showed efficacy was consistent irrespective of age, sex, race, ethnicity, and comorbid conditions. The adverse events observed were consistent with those seen in previous studies with no safety signal identified. There were no cases of myocarditis or pericarditis observed. Lymphadenopathy was higher after a booster dose at 2.7% compared to 0.4% that we've seen in previous studies. Overall, these data strongly support that a booster dose of BNT162b2 administered in individuals 18 years of age and older, these greater than 6 months after the second dose, improves protection against symptomatic COVID-19. Thank you very much, and I'd be happy to answer questions.
Thank you, Dr. Perez, and this presentation is now open for questions. Dr. Paling.
All right, can you hear me?
We can, thank you.
All right. Okay, great. Thank you, Dr. Perez, for a great presentation on a really important study. I've got 2 questions. The first question is, I did see that about 60% of the persons were 16 to 55 years of age. It also looked like 16 and 17-year-olds, it was less than 1%. do you have the breakdown on how many people were like less than 24 years of age, or what the breakdown within the 16 to or 18 to 55-year-old age group is?
We do have some data on that. Give me 1 second, please.
Wonderful.
All right. Okay. In terms of efficacy, are you asking about?
Yeah, well, that's what I want to know, how many people and what is the efficacy when you go to the younger age groups? Yes.
Certainly. So where we have enough information to have confidence intervals that are greater than 0. We have such confidence intervals in people 16 to 25, 16 to 30, 18 to 30, 31 to 40, and also 16 to 40. The estimated relative vaccine efficacy in all of those groups is 100%.
Okay, and can you just tell us roughly how many people are in the 16 to 25 age group, please? Thank you.
Yes, there was 0 in the vaccine group, and there were 7 in the placebo group in the efficacy analysis, with the relative vaccine efficacy of 100%, with the confidence interval from 26 to 100.
Okay, I was trying to get the denominator. How many are in the 16 to 25 age group? Thank you.
I would have to pull that up for a second. Perhaps we go on to the next question. I'll return to that.
Yeah, that would be great. If one of your team members could pull that up for you, that'd be wonderful. We'll move on to Dr. Brooks.
Yes, thank you for the presentation. The question is, did you measure GMTs on the patients that were in the study? And I ask because I'm wondering if we can maybe, roughly extrapolate out how long this protection with the booster may last.
The GMTs were measured in the prior study, the 1001 study. This was the data set that was previously presented in approximately over 300 individuals, and that was the basis for our initial approval. This was the non-inferiority analysis that we did for our initial EUA submission. We did not collect sera in these 10,000 individuals to do immunogenicity.
Thank you.
And just to follow up on Dr. Brooks's question, will you be doing follow-up on those 300 individuals in 1001?
Yes, we're following them up till at least 6 months after they've gotten their booster dose. We're following all the subjects up to at least that far. And various studies have commitments to go to follow up subjects for safety for up to 2 years.
Thank you. We'll move on to Dr. Lair.
Thank you very much for your presentation, and thank you all for doing this study. It's actually very valuable information. I'm wondering if you could talk a little bit more about the surveillance that you did. In your last slide, you talk about symptomatic COVID-19, which implies that you were waiting for people to have symptoms before you would test them. And so that makes me assume that you're not doing asymptomatic testing or anything like that. Just want to clarify your surveillance process. Thank you.
Sure. The surveillance process is the same as we've used previously. Namely, you had to have symptoms consistent with COVID-19, typically a respiratory illness. If that occurred, then subjects either self-swabbed for PCR or came into a site to get a PCR tested. And then, so if you had symptoms plus a positive PCR, then you were considered to have symptomatic COVID-19. We did not, in this study, did not test for asymptomatic infection. That's being done in another study.
Thank you. We'll move on to Dr. Long.
Thank you, Dr. Perez. It's a question about the lymphadenopathy. The lymphadenopathy, was it all axillary? What percentage was in women as opposed to men? And as I have seen people and their boosts, especially in the younger age group, maybe still menstruating women, they've had not lymphadenopathy, but have had a painful swelling of the soft tissue. So would that have been captured? Thank you.
Yeah, overall, the lymphadenopathy that we saw was primarily ipsilateral to the injection site. We do sometimes see lymphadenopathy also in the cervical regions, and usually, again, it was ipsilateral. Tended to occur about 8 or 9 days after the first dose, and then about 3 or 4 days after the second dose. And these were all, palpable but soft lymph nodes that could be easily noted on exam. There was no obvious sex difference in this analysis, although we have seen it appear in a few analyses a little bit higher in females as opposed to males.
And was it mainly in women?
No, men also reported lymphadenopathy.
And did you have reports of swelling, painful swelling without lymphadenopathy?
We had a few reports of lymphadenitis, which I'm assuming is getting to the sorts of syndrome, clinical syndrome that you're getting at.
Thank you. We'll move back to Dr. Paling, and hopefully you'll have the denominators as well.
Okay. I want to follow up on Dr. Lear's question and go to slide 16. And this says subjects without evidence of infection. Okay, so you're saying these are the people that became symptomatic after day 7? Is that right?
Yeah, so what we mean by with or without evidence of infection, it means whether prior to coming into the study, whether they had COVID-19. So we determined that initially when they enrolled by PCR test, and also by looking at antibody and binding antibody at baseline. So if you were PCR positive initially, or you had you were N binding positive, you were considered that you had evidence of infection.
Okay, so these are the people who, when they entered, had no evidence of infection before the primary series, and then developed evidence of infection during this booster period. Is that correct?
Not during, it was before the booster period. Right.
Okay.
So in order to be considered with evidence of infection, you had to have evidence prior to the booster, and then we follow people afterwards to see if anyone develops COVID-19 afterwards. And we did pick up a few cases of people who were positive at baseline and who developed SARS-CoV-19.
Okay, but all of these people are symptomatic with the illness to be tested positive.
Correct.
No asymptomatically tested. Perfect. All right, thank you. I appreciate that clarification.
Thank you. And
no problem.
Dr. Perez, do you have the denominators by chance before I forget? If not, we can move on to the next question.
Yes. All right. So you're looking for how many 16 to 17s there were? Mm-hmm. There were 78. 16 to 25, there was 472. 18 to 30, there was 933. 18 to 30, there was 855. 31 to 40 was 1,414. And overall, from 16 to 40, there was 2,347.
Okay, thank you.
Thank you. We'll move on to Dr. Daly.
Yes, thanks so much. Could you please go to slide 14? I have several safety questions. So could you just describe, do you have additional clinical details about this very first case? I'm understanding that this is somebody who had pre-existing postural orthostatic tachycardia syndrome, and then it may have been exacerbated by, or at least we attribute the exacerbation to vaccination. And what were there additional clinical details that you could provide? Thank you.
Yeah, certainly. So when this individual, well, first of all, this individual was seen in the emergency room for the tachycardia, where his heart rate at the time was 140 and his blood pressure was about 145/93. He had an ECG, a chest X-ray, an echo, and troponin tests, all of which were normal. He had an elevated D-dimer, so there was concern about a clot, and so a chest CT was done to rule out pulmonary embolism, and it was normal. He was discharged on metoprolol, and then he returned to the emergency room a few days later due to tachycardia. His heart rate decreased after taking metoprolol, but he had stopped taking it in between visits. He was evaluated by a cardiologist soon after for a postural tachycardia, which normalized upon sitting. He was prescribed increased salt intake, daily metoprolol, and compression stockings. He went back to the emergency room due to tachycardia and emesis. He had stopped taking the metoprolol again. He was treated with fluids, antiemetics. D-dimer was still elevated. He got an ultrasound of the lower extremities, which were normal. And then he had follow-up with the cardiologist for a 2-week cardiac event monitor, and the results were normal. That's all I have on the case.
Thank you.
Thank you. Dr. Sanchez? Dr. Sanchez?
Yes, thank you. No, I was trying to find the button. No, thank you for that. And actually, along with that, that comment and that explanation of the young adult male, I was actually wondering, was there any, I mean, you had a wide range of receipt of the booster after the primary series. And did you see any correlation with timing and adverse effects that were reported? And so when did this young adult male receive his booster compared to the initial, to the initial primary series? And I guess because of the, is it 6 months? Is it 8 months, 10 months, or what ultimately?
I don't have his dates of vaccination on me. However, we knew it had to be at least 6 months prior to final second dose for this. And what we saw was that the vast majority of people were at the 10-month mark. But I don't have his vaccination dates available right now.
Because, I see that a few actually received it less than 6 months, some 6 months to 8 months, 8 months, from slide number 5. I think it would be helpful to know if there was any crowding of adverse events reported by the timing of the booster. And also, it would be helpful, I don't know if any of these individuals who had some, reported adverse effects were those who reported similar adverse effects previously with the primary series or had any issues with primary series.
This found it. This person completed their vaccination in July. The analysis was done in October. That was the booster. Sorry, that was the booster.
So are you saying that was 4 months after the vaccine? After the primary series?
No. The primary series was completed November 25th, 2020. The subject was given a booster in July of 2021.
Thank you. And I'm sorry.
About 8 months later.
8 months. Okay.
Yeah.
And you did not see any crowding of effects dependent on the timing of the booster, or you haven't, you did not study that?
We didn't really look at it from that perspective. However, in review of all adverse events, there was nothing that stood out. in the vaccinated group compared to the placebo group, other than what I reported, reactogenicity and lymphadenopathy.
Dr. Lee, I have a few other questions. Can I go, or should I go with that?
Are they clarifying questions related to this presentation?
Yes.
Okay. I think we'll have to go quickly because we're already behind schedule, Dr. Sanchez, and I'm cognizant of the fact that we also will need to end as close to on time as possible, else we will lose some members. So if you can be efficient, I'd appreciate it.
Okay. I just wanted to know the basis for the documentation of the past infection. Was that based on antibody testing, like nucleocapsid, or did they have, I assume that they did not have any known COVID infection previously?
It was based on antibody testing and PCR testing when the subject first enrolled into the study. And it's the end-binding antibody test that we performed.
Anything else, Dr. Sanchez?
I don't think so. Thank you.
Okay, thank you. And Dr. Brooks, you still have your hand raised. Is there another question? Thank you. Dr. Eckert.
Yes, I was just wondering if you had any data on pregnancy and boosters in your cohort.
None of the subjects were pregnant
Okay,
in this particular cohort.
Okay, thank you. And with that, we actually have one more presenter. So what I'll ask is that the Pfizer team hopefully will remain on the line. So if additional questions come up later during the later presentations, we'll call on you. In the meantime, Dr. Rituparna from Moderna will share updates from the Moderna team.
Hi, everyone. Thank you. I'm Rita Das from Moderna, and I'd like to give you an update on our 50 microgram booster dose of the Moderna COVID-19 vaccine in individuals greater than 18 years of age or older. If you'll go to the next slide. I'd just like to kind of review the EUA that was just granted this morning for the extension to all 18 up for the use of the Moderna vaccine as a booster. This is again the 50 microgram dose, and so the volume is 0.25 mL. And as Dr. Fink mentioned, the administration is 6 months after completing the primary series for the homologous boosting, and then according to each vaccine's individual series for the heterologous boosting. If you'll go to the next slide, we'll kind of just review the data we presented to you previously at the October 21st ACIP meeting. And this was the data package that was used for our original 50 microgram booster emergency use authorization. And again, we did use the immunobridging approach per the FDA guidelines for boosters and variant vaccines. So going over the safety first, the rates of adverse reactions following the 50 microgram booster dose were comparable to that seen after dose 2 of the primary series. And the comparison is the primary series received in our pivotal study, Protocol 301 or COVE. The pain at the injection site was the most common solicited local adverse reaction. Headache, fatigue, and myalgia were the most common systemic adverse reactions. The majority of the adverse reactions were mild to moderate in severity. And as has been part of the discussion and was part of the discussion last time, axillary swelling or tenderness was the only adverse reaction that was more frequently reported after the booster dose compared to dose 2 in our primary series study. There were no vaccine-related serious adverse events or deaths in our booster study. That's Protocol 201B. If you'll go to the next slide, I'll go over the immunogenicity endpoints and analyses. So the pre-specified co-primary hypotheses, again, were the geometric mean titer ratio and the seroresponse rate difference post-booster compared to post-dose 2 of the primary series. Our booster study had kind of two schedules in there. there was a 50 microgram primary series followed by a 50 microgram booster, and a 100 microgram primary series followed by a 50 microgram booster. So on the pooled analyses, all of the pro-primary endpoints were met, but I'll focus a little bit on the 50 microgram primary booster following the 100 microgram primary series, which is what everyone will get. There was a higher antibody response to the original virus than compared to post-dose 2 in our pivotal efficacy study. That GMR was 1.8. There was a 13-fold rise of antibodies compared to pre-boosters against the original virus. There was a 17-fold rise from pre-booster titers for the Delta variant, and these results were very consistent in the younger 18 to 64 as well as the older age group. If you'll go to the next slide, I'll give you a summary of the booster work that is ongoing now. So for Protocol 301 or COVE, our efficacy trial, we started boosting. We started boosting in that study in September, and to date we've boosted more than 15,000 participants. The range of time for the booster is anywhere from 6 to 14 months after completion of the primary series. The safety and immunogenicity data from that cohort are being compiled. There have been no unexpected signals that have been seen, and we will bring forward the safety and immunogenicity data as soon as they're available. We're also looking at the 6-month persistence of antibody in our booster study. So this will have the 300 subjects who were boosted with the 50 micrograms. They've hit their 6-month mark, and those sera are currently being tested. So we'll put all our data together for the work group and the ACIP as soon as they become available. So, that takes care of it for the update from the Moderna side, and we're also happy to take any questions.
Thank you, Dr. Doss. Are there any questions for the Moderna team? I'm not seeing any new hands raised. Oh, there we go, Dr. Daly.
Thanks very much for that. So just a quick question about timing. So am I correct in understanding that the bulk of this data will be among patients who started receiving a booster in September of 2021, so that right now there's individuals who have about 2 months of follow-up, and then maybe there's also individuals who are vaccinated and received a booster in October, and so it'll be sort of a couple months after that we may be able to hear an update about this?
Yes. We're boosting the whole study. So all of the participants are getting a booster, and so we are actually doing a cutoff now so that we can compile all of the data from the first 15,000 participants so that we can analyze those data in a more expedited time frame. So yes, so the cutoff now will have people who have about 2 months of follow-up and people who are more recently boosted.
Thank you.
Thank you. Dr. Sanchez?
So my question, at the time of the booster, how many, I know that they responded with significant antibody response after the booster dose. But at the time of the booster, how many, what was the levels of antibodies did you document waning antibody levels, neutralizing antibody levels during that time period after the primary? And yeah.
Yes, no, we did. I mean, the antibody levels post, pre-booster were certainly higher than, pre the primary series. Most participants still had detectable antibody levels, but there had been a waning of antibodies. And so and particularly, most of the subjects had antibody detectable for the prototype strain for Wuhan, but about 50% of the participants had lost detectable antibody levels for Delta. So, yeah.
Thank you.
Thank you. Dr. Long?
Yes, is there clinical efficacy involved with this trial?
So this is not a placebo-controlled boosting trial. At the time that we started the trial, we thought that we could not do placebo-controlled boosting anymore. We are doing case monitoring the same as we've always been. And over this at the last presentation, we showed you the breakthrough case data for early vaccinees versus late vaccinees, and how early vaccinees seem to be having more breakthrough cases. And so we're continuing the case monitoring exactly the same way. Anytime somebody gets symptoms, they come in for PCR testing, and then they're followed to resolution. We're also doing sequencing for all of the cases. And so we will have incidence rates over different times, so pre-boost, including post-boost, but there's not a placebo-controlled efficacy.
Thank you. We'll move on to Dr. Cotton.
Yes, I take care of immunocompromised patients, and this is a little bit off topic, but I was wondering if you could address thoughts about immunocompromised patients who had J&J, who are now recommended to get the 50 microgram booster Moderna dose 2 or more months after their J&J. And I am getting a tremendous number of questions about that. I was wondering if you had any further comments or input on that one. Many clinicians want them to get a full dose Moderna after J&J for the immunocompromised. And this is the people who meet the definition of moderate to severely immunocompromised.
Yeah, I mean, we have an immunocompromised study where we're studying kind of the third dose, and we'll probably extend that study into a fourth dose as well. But Dr. Cotton, it doesn't exactly cover your question, because it's, there's not a recommendation for kind of the third dose for the J&J vaccine. So, unfortunately, I don't have any data on that, and I'm not sure how else.
I think all of us.
Yeah.
Thank you. I think all of us are struggling with that one, but I appreciate the support.
Thank you. Dr. Eckert, you have your hand up. Did you have any?
Yes, I was just wondering if this cohort of patients had any pregnant individuals in it. Thank you.
So we are following everybody for pregnancy. I haven't seen any reports come through, but we'll certainly compile the data altogether.
Okay. Dr. Brooks.
Yes, so you say immunogenicity data expected on the subset in early 2022. About how many do you expect to be in that subset?
So we are actually trying to keep the same immunogenicity subset of participants who've stayed with us through the whole trial. So that started out as about 1,000 people, and I believe about 700-800 will be left after we exclude, people who've had prior COVID infections that would kind of interfere with the interpretation of the antibodies. So definitely higher than 500, but lower than 1,000.
And this would be what you may be submitting for data for further evaluation and approval.
Yes, exactly.
Thank you.
Thank you. I actually just wanted to make one quick comment to both our Pfizer and Moderna colleagues. I just to summarize what I'm hearing from the ACIP members, we're really appreciative of the continued information on vaccine efficacy and safety by prior infection status. That will continue to be helpful for us going forward. I think we also appreciate further assessments on the impact of dosing intervals on efficacy and safety, and a continued focus on the age and gender-specific safety data as you have been. But we'll continue to see questions on that in the future. I also just wanted to endorse one of the questions that was raised, which is that we need to really continue vaccine clinical trials that are inclusive of children and pregnant women. These questions keep coming up, including for booster doses, and we are typically behind sort of the general adult population. And finally, it sounds like we're going to continue to benefit from correlates of immunity and look to our FDA colleagues to help guide us on that. Dr. Sanchez, did you have another question?
Yes, I just wanted, I wasn't fully, I have some questions about the pregnancy issue because I wasn't clear on the response. So were pregnant women enrolled at the time of the booster dose? Or did you say that you didn't know on pregnancy outcomes following that? I'm a little bit unclear. Were you, among all these participants that you studied, were any pregnant at the time of the booster dose?
Yes, so thank you for that clarification. The active pregnancy was an exclusion for getting a booster in the trial. Whether women have subsequently become pregnant, I will have to check the database for that. We are also doing a pregnancy registry as well as an effectiveness study among pregnant women in our observational among the cohort of our observational studies. And so, we hope to bring forward those data soon as well.
And that will include pregnant women who get a booster during the pregnancy.
No, I will have to check with my EPI colleagues, but yes, actually that is correct. Okay. It will include women who get boosted during pregnancy. Yeah. And I believe this will be around 5,000 women as a whole in the study.
I just want to echo Dr. Lee's comments that we really, that data that population is very important.
Thank you. Dr. Long, I'm going to give you the last question.
Oh, thanks so much. It's brief. I'm interested in the 50% who were antibody delta negative at the time or pre-booster. Was there an age-related occurrence of that, or did that cross all age groups equally?
We will have to go back and take and actually, I'm sorry, I misspoke. This was from the phase 1 study, the 50% that were delta, that were antibody negative. We do have delta testing subsequently on this cohort. We have to take that back and do the analysis. There is data from our from the real world effectiveness study, the Kaiser Permanente study that is posted on medRxiv, that does show that there is more waning of efficacy of effectiveness against COVID with the caused by the Delta variant compared to other variants. So while efficacy starts around effectiveness starts around 80% or 90% or so in that study. Across all age groups, the waning is higher for Delta compared to non-Delta.
Okay, thank you very much. And with that, I want to thank our presenters, and we are going to recess for a very short break of, we're going to say back here at 23 minutes after the hour, and we'll return for public comment. Thank you.